Di email ya dok ya?
Rahul, halo Rahul.
Diliana udah ada.
Sudah, Dr. Diliana sudah.
Sudah dok.
Sudah hadir, semua pembicara dan panelis sudah siap, host dan moderator juga sudah siap.
Ya, Dr. Boy, dok izin ini kami mungkin bisa mulai broadcast untuk peserta gitu.
Ya, silakan Imran.
Oke. Ya, professors, doctors, in short, I'm going to broadcast the event so that the attendees can join this webinar. And then we are also going to record it live to the cloud. And for your information, this event is currently live on YouTube. We are going to start the event by opening remarks from the organizing committee, Wina Widiarti. Okay, and I'm going to start the broadcast, yeah, for doctor seniors in 3, 2, 1. We are now live and the attendees can join this event. Okay, Wina, you may start this event. Thank you.
Good afternoon, ladies and gentlemen. Welcome to the 23rd Airlangga webinar conference series, Clinical Pharmacology of Antiviral and Supportive Treatments for Patients with COVID-19. My name is Wina Widiarti, along with my senior Dr. Ahmad Heriana, Specialist of Pediatrics, and my colleague Dr. Karin and Dr. Imran, Rahul, and Arya. We are the organizing committee members of this webinar. This webinar is organized by the Faculty of Medicine Universitas Airlangga, Surabaya. We are happy to announce you that up until now, the registrants have reached 878. Before we proceed to the main event, we will announce some of the rules regarding the certification and Q&A session of this webinar. Rules for ED accredited certification. Full participation during the webinar is required. Your attendance will be recorded by the Zoom application. Of this webinar, participants are required to fill a questionnaire which the committee will send the link of in the chat box. The certificate will be sent to your registered email address. Next. Rules for Q&A. Use the Q&A box on the middle of your Zoom panel to write down your questions. Questions will be sorted and discussed after all lectures have been presented. Thank you for your participation and we sincerely hope you enjoy this webinar. We will start this event with an opening remark from our beloved host, Dr. Annette. Dr. Annette, the time is yours.
Good afternoon, ladies and gentlemen. Welcome to the 23rd Airlangga webinar conference series. My name is Annette Erkom from Department of Pharmacology, Faculty of Medicine, Universitas Airlangga. My warm welcome to the distinguished speaker, panelists, and all attendees. In today's webinar, we will discuss about the clinical pharmacology of antiviral and supportive treatments for patients with COVID-19. It will be divided into two sessions. The first session will discuss about the CPG in Thailand, clinical practice guideline in Thailand for COVID-19, and the use of Favipiravir in Thailand. And the second session will be the use of the azithromycin and anticoagulant in COVID-19. The question and answer will be held in both sessions. And for today's discussion, the leader will be our beloved head of department, Dr. Arifa Mustika. Dr. Arifa, please, the floor is yours.
Thank you very much, Dr. Annette. Assalamualaikum warahmatullahi wabarakatuh. Hamidandillah wa musolliyan ala rasulillah. Good afternoon, everyone, and welcome to our distinguished guests and all participants. Thank you for being here this afternoon in the Airlangga Conference webinar series. My name is Arifa Mustika and my duty is as moderator. Since the announcement of the SARS-CoV-2 outbreaks in December 2019 by WHO, until now, the definitive therapy on COVID-19 has not been agreed. There is no precise treatment for coronavirus, but some approaches has been used, such as prevention, management, and supporting healthcare may provide relief in the outbreak of COVID-19. Therefore, in this occasion, in the noon conference, we try to share our knowledge, our experiences about the management of COVID-19 patients. This afternoon conference will be held in the following manner. In the first session, we will listen the presentation from Associate Professor Pinyo Ratana Ampawan, MD, MSc, PhD, and we will continue with discussion, question and answer. The second session, there are two speakers. The first speaker is Dr. Didiana SPFK, and the last speaker is Dr. Abdul Khairul Rizki Purba SPFK, MSc, PhD. The third session is discussion. We will seek the opinion from our two panelists, Dr. Nafrialdi SPFK, SPPD, PhD, and Dr. Maftuhah Romanti, Dr. MKes. After that, participants can ask questions to both speaker and panelists with writing in the Q&A panel in English or Bahasa. Today, we are pleased to welcome Associate Professor of Medicine Pinyo Ratana Ampawan, MD, MSc, PhD, a very special guest from Division of Infectious Disease and Tropical Medicine, Department of Medicine, Faculty of Medicine, Sirirat Hospital, Mahidol University, Bangkok, Thailand. Within 30 minutes, she will be sharing with us her expert opinion about Thailand clinical practice guideline for management of COVID-19 and experiences on Fabiravia for treatment of COVID-19. Please, Associate Professor Pinyo Ratana Ampawan, you can start your presentation.
Thank you, Dr. Mustika, for the great introduction, and I would like to thank the scientific committee for inviting me to join this event. May I share my screen right now? Okay. Okay, so today the title of my talk is about Thailand Clinical Practice Guideline, or CPG, for management of COVID-19 and my experiences on Favipiravir for treatment of COVID-19. And this slide shows the disclosure over the past 3 years. Okay, this slide shows the outline of my presentation today. First, I will briefly talk about an overview of antiviral therapy for COVID-19. Then I will talk in detail about Thailand CPG for management of COVID-19. And at the last, I will share my experiences on Favipiravir therapy among my COVID-19 patients. So let's start with the first one. Before starting, I would like to make sure that everyone exactly understands the terminology of COVID-19 disease. The coronavirus disease 2019, or abbreviation as COVID-19, is a disease, but it's caused by the severe acute respiratory syndrome coronavirus 2 that we call SARS-CoV-2. So COVID-19 is a disease and SARS-CoV-2 is a causative pathogen. And this slide shows possible mechanism of all potential antiviral agent. First, you can see on the left-hand side here, I'm not sure. Okay, here is a SARS-CoV-2 virus. And when it enters to the human cell, it needs the mechanism of membrane fusion and endocytosis. So if we use arbidol, chromostat mesylate, or chloroquine hydroxychloroquine, it can inhibit mechanism of membrane fusion and endocytosis. For protease inhibitors such as lopinavir and darunavir, it will inhibit proteolysis mechanism. For ribavirin, remdesivir, favipiravir, It will inhibit RNA-dependent RNA polymerase or RDRP. So if we use these two antiviral agent group, it will inhibit RNA synthesis and virus cannot replicate. Sometimes physicians may use targeted therapy such as anti-interleukin 6 receptor inhibitor, including tocilizumab and sarilumab. These two agents can inhibit interleukin to activate macrophage, so then we can prevent cytokine storm that cause ARDS in the patient. As we know that we have many proposed antiviral agents, but right now, as my knowledge, there are only few antiviral agents that be proved to be effective in the large randomized control trial. So right now, only Fabiravia, remdesivir, and combination therapy of interferon alpha, ribavirin, and lopinavir, ritonavir shows promising efficacy in randomized control trials. So let's go about the CPG in my country. So if you are very interested in Thailand CPG, you can go to this website at the below of the corner here. It's a Thai CDC or Thai Department of Disease Control website. We update information regarding the situation in Thailand every day, and all information regarding COVID-19 will be available at the recommendation tab here. So you can go and check it because it's also available in English version. And this slide on the left-hand side show Thai version of our CPG, and on the right-hand side show English version, the CPG, but no worry, I will translate into English and tell you in detail. So at the beginning, Thailand CPG will categorize patients into 4 groups. The first one is a symptomatic patient group. The second one, mild symptom patient without any risk factor for severe disease. The third group, mild symptoms with risk factors with any risk factor for severe disease. And the last one, any patient with pneumonia. So we can diagnose of pneumonia by having at least one from the 2 criteria over here. Abnormal chest in imaging such as chest X-ray or CT scan. Or desaturation, we use the cutoff point of oxygen saturation below than 95% or less. So after we categorize patients into 4 groups, we can check whether they have risk factor or not. And this slide shows our significant risk factor in our clinical practice guideline. Elderly patient more than 60 years, having lung disease, having cardiovascular disease or congenital heart disease, having poor control diabetes, having chronic kidney disease, history of stroke, body mass index more than 35, having cirrhosis or immunocompromised host, and also if the CBC show lymphopenia with a lymphocyte count less than 1,000 per ml. So if they have only one criteria from this slide, we will consider that they have a risk factor for severe disease. After we categorize patients into 4 groups, we recommend treatment as shown in this slide. For asymptomatic patient, no specific antiviral is recommended. However, we will admit all patients, all asymptomatic patients to observe for at least 2 to 7 days in our hospital to make sure that they will not develop pneumonia or other severe complication later. After 7 days after the onset of symptoms, we move patient into the hospital. Hospital is a specifically designed hotel that we use to quarantine our good clinical patient. And we ask them to stay in a single occupancy room, and we ask the patient to record their own vital sign every 6 hours, and they communicate their own vital sign and their own symptom to the medical team via online application. So after they stay in the hospital until complete 14 days after the symptom of onset, we ask them to go back home and do home quarantine until complete 30 days after the onset of symptom. For patients with mild symptom but without risk factor, we recommend exactly the same recommendation for quarantine, but during hospitalization, we offer 2 medication for 5 days. And we choose 2 medication from the list. Choice of antiviral agent include the first option is chloroquine or hydroxychloroquine. The second option here is protease inhibitor, either darunavir, ritonavir, or lopinavir, ritonavir. And for the azithromycin, it is the last option because they have limited evidence at the moment. For the patient with mild disease, mild symptom, but with any risk factor for severe disease, we recommend to use 2 or 3 drugs from the list. The list for antiviral agent is exactly the same as a mild symptom no risk. So in this group, we usually use 2 antiviral agents. In this group, we usually use 3 antiviral agents if patient can tolerate. But for patient with pneumonia, we recommend to use 3 to 4 antiviral agents for at least 5 to 10 days. Is the duration of antiviral agent depending on the patient's severity. And the first option for patient will be Favipiravir. So everyone with pneumonia will receive Favipiravir. And then we ask the responsible physician to choose at least 2 from 3, from chloroquine, from protease inhibitor, and from azithromycin, at least 2 from the list. So half of this patient will receive 4 medication and half of this patient receive 3 medications. And this is the Thailand CPG that we use up until now. However, as we know that there are many evidence based out there and many published study on antiviral agent, we plan to revise our CPG, and I hope that this CPG will be available before the end of this month. So based on the previous study, we found that azithromycin, that the second speaker will talk about this later, but we believe that azithromycin may do more harm than benefit. So we plan to remove azithromycin from our clinical practice guideline. And although chloroquine, hydroxychloroquine, and protease inhibitor did not show great benefit in previous study, we still keep it in the guideline. Additionally, we saw many, I think at least 3 large randomized control trials to confirm that remdesivir is seem to be useful among pneumonia patients. However, right now, remdesivir is available in Thailand, but in a limited amount. So we will put remdesivir in the guideline, but after we try to use favipiravir first. But if patient cannot take favipiravir, such as they cannot, they have the poor GI absorption, something like that, we will recommend to use remdesivir as an alternative agent. So one patient will receive either favipiravir or remdesivir. We will not use both at the same time. And we still recommend to use chloroquine and protease inhibitor in all symptomatic cases. And this is the latest guideline that will be available soon in our country. So as you can see that our guideline very prefer favipiravir for pneumonia patient. We have a lot of experience on favipiravir therapy before it become available in other country. And before we start with our experience, I would like to show you the basic information regarding favipiravir. Favipiravir is a purine nucleic acid analog that can block IDRP of RNA virus, as we show here. The trade name is Avigan. The generic name is favipiravir. It shows very good in vitro activity against many RNA virus, including Ebola, influenza, and SARS-CoV-2. Right now, favipiravir is freely available in Japan for treatment of influenza infection. And they recommend, the standard recommended dose for favipiravir is 1,600 milligram twice a day on day 1 and 600 milligram twice a day on day 2 to 5. For influenza, they recommend to use just for 5 days. The maximum dosage that can be used safely in previous literature is 3,000 milligram BID twice a day on day 1 and 1,200 milligram BID on day 2 to day 9. And this is the basic information that I would like to tell you about Fabiravia. So let's check my experiences. You can see here, this is an unpublished study of my own. You can check it on Medtreat IV. I already uploaded my preprint version over there. We conducted a retrospective observational study at 5 tertiary care hospitals in Thailand, at Sirat Hospital, my own hospital, Lersin Hospital, Taksin Hospital, Washila Phuket Hospital, and also Central Hospital. We conducted this study for 5 months, January to May 2020, and the study was early terminated because we have no more cases in our hospital. And we enroll all hospitalized adult patient age over than 18 years. Then they must have at least one positive SARS-CoV-2 PCR test from any respiratory specimen and receive at least one dose of favipiravir therapy. Given that favipiravir therapy was made available under emergency procurement by Thai CDC, so it was restricted to use among patients with pneumonia only. So in this case series, only patients with pneumonia will be included. And this is the recommended dose by Thai CDC. If patient BMI is below than 35, we use the standard doses as we use in the influenza patient. But if the patient BMI more than 35, we use 60 milligram per kilo per day on day 1, and we use 20 milligram per kilo per day on day 2 to 10, and we split dose as a twice daily dose. And we focus on 3 important critical outcomes. The first one was NIMS-2 score, which is a composite endpoint of body temperature, blood pressure, pulse rate, oxygen saturation, and consciousness. The second critical outcome, the critical endpoint, was 6-point severity scale or 6PSS. 6 is death, 5 hospitalization for ECMO or mechanical ventilation, 4 hospitalization for non-invasive ventilation or high flow nasal cannula, 3 hospitalization for any kind of oxygen supplement, 2 hospitalization without any need of oxygen supplement, and 1 discharge or normalization of all vital signs and oxygen saturation for more than 24 hours. And the last outcome of interest was clinical improvement, which is at least 1 point reduction in baseline 6 PSS score when comparing to the first day of favipiravir therapy. So you can see here, this is the baseline characteristic of our 63 cases with pneumonia who received favipiravir therapy. Median age in our study was 48 years. More than half were male. Average body weight was 69 kilogram. Median NIMS-2 score was 5, which is quite high when comparing to other study. And approximately 40% of them had pneumonia, but did not require extensive oxygen supplement or any kind of oxygen supplement. 40% of them require oxygen cannula. 6.4% of them require BiPAP or high flow nasal cannula, and 6.4% of them require mechanical ventilation or ECMO. And when we focus for other medication used in this group, nearly all of them strictly follow our CPG. So approximately 98% or nearly 100% of them receive chloroquine-based agent and protease inhibitor. And half of them receive azithromycin, 12% receive steroid, 6.4% receive tocilizumab, which I quite impressed with the tocilizumab. Is a very good drug, but very expensive drug as well. And when we focus on favipiravir regimen, you can see here that the median loading dose was only 47. Median maintenance dose was only 17 milligram per kilo per day. and 1/3 of the patient receive low loading dose less than 45 milligram per kilo per day, and 2/3 of them receive low maintenance dose less than 15 milligram per kilo per day. So you can see here is our baseline characteristic of our patient. And this slide show rate of clinical improvement, which mean reduction in 6 PSS score on day 7, day 14, and day 28 after favipiravir therapy. You can see here that we divided patient into 3 groups. Overall patient here, patient who did not require any oxygen supplement, and patient who require oxygen supplement. Patient who require oxygen supplement including nasal cannula, high flow cannula, ventilation, and also ECMO. So the among those who did not require oxygen supplement, clinical improvement was 92% on day 7, 100% on day 14 and day 28. So nearly all of them completely recover within the first week. But for patients who require oxygen supplement, only half of them have had clinical improvement on day 7. 75% of them had clinically improvement on day 14, and 80% of them had clinical improvement on day 28. So it's not quite good, but it's considered good when comparing to other study. For other parameter for treatment outcome, you can see here 28-day mortality was approximately 4.8%, but in hospital mortality was 7.9%. More than half of them experienced adverse drug reaction. The most common adverse drug reaction was diarrhea, followed by nausea, vomit, hepatitis, and QT prolongation. But we may unable to say that these are side effects of favipiravir because nearly all of our patients also receive protease inhibitor, chloroquine, hydroxychloroquine, and also azithromycin. So we try to explore what would be the predictor for early clinical improvement on day 7. So we divided patients into 2 groups. The first group was the patient with good clinical improvement, 42 cases, and 21 without clinical improvement on day 7. You can see here that median age of patient with good clinical outcome seem to be lower, and they also had a lower 6 PSS score, which is a quite common sense. And you can see here that nearly all of patients who require BiPAP, high flow nasal cannula, ventilator, or ECMO, nearly all of them did not develop good clinical improvement within the first 7 days. And another potential difference between 2 groups was loading dose of favipiravir. If they receive the lower dose, it tend to be in the worst clinical outcome group. And also azithromycin. 40% of patients with good clinical outcome receive azithromycin, while 66% of the patients in the poor clinical outcome group receive azithromycin. However, we can say that patients who tend to be sicker may receive more drug, or all of characteristic that we mentioned before is a predictor for severity of illness. However, we do the multivariate analysis to adjust for all confounding factor, and this slide show result from our multivariate analysis. We identify 3 independent associated factor for day 7 clinical improvement. Here, 8 baseline used to score and low loading dose of favipiravir. And you can see here, adjusted OR were below than 1. This means this are poor predictor. Is a poor prognostic factor for clinical improvement, for early clinical improvement. So in conclusion, based on our finding, I would like to say that favipiravir show promising effectiveness. However, we always use in the combination with chloroquine and hydroxychloroquine and protease inhibitor. However, the effectiveness in our study was quite high when comparing to other regimen in other study. And we also identified three important poor prognostic factor in this study: older age, higher baseline used to score, and receiving a low loading dose of favipiravir, which we use a cutoff point of 45 milligram per kilo per day. And we believe that the further study is in need to further evaluate the optimal dose and optimal timing of drug initiation, because right now Favipiravir is available worldwide, and I believe that the early initiation may be more beneficial among our patients. In the CPG, we start when they develop pneumonia. It would be better if we can start Favipiravir in an early stage, such as a patient with mild symptom but with severe risk factor or something like that. So I think I will end my talk here and open for the floor discussion.
Okay, thank you, Pio, for your interesting presentation. I think your presentation invited many curiosities. According to your presentation, the management of COVID-19 patient use multiple approaches based on clinical symptom and science. So the outcome of patient with favipiravir treatment also based on clinical symptom or science.
Yes.
So I will start the discussion. The first, I welcome our panelists, Dr. Maftuha, Dr. Majlis Kesehatan, to give comment or question to Associate Professor Pinyo Ratana Ampawan. Please, Dr. Maftuha.
Yes. Thank you, Dr. Arifa. Good afternoon, and all of the audience in this webinar. Thank you for your very good presentation, Prof. Pinyo, and I interest with your research that about the favipiravir, and maybe I don't give a comment, but question maybe, yeah, at the first. So your research is about the low dose of favipiravir, and this you say that in conclusion that poor prognostic factor for early clinical improvement, yeah, for low loading dose of favipiravir. So maybe you can explain to us what about the variation of the dose for the clinical outcome? Maybe you have experience and you will share with us.
So, the
Yeah.
question is why I think that low. How can I explain that low loading dose of favipiravir therapy become
Yes.
poor prognostic factor for COVID-19 disease, right? Okay.
Yes.
So I think if you go through the literature, they are only few PK/PD study regarding favipiravir therapy. But as I come across the PK/PD literature, I saw that it's based on the is based on the previous study, which we found that 1,600 milligram per kilo per 1,600 milligram BID on the first day may be inadequate in some group of patients. This recommended dose based on study in Japan, which I believe that the body weight is uh, quite low. But when we use exactly the same dose in Africa, which the body build may be bigger, they found that effectiveness is not is not quite good among Ebola infection. But I'm not sure if we can applicable this information to our study. However, because obesity and higher BMI is an important risk factor for severe COVID-19 disease. In our hospital, more than 20% of our patients has body weight more than 80 kilograms. Or patient with severe disease have a very big body weight. And someone asked me that they may get the poor clinical outcome because they are fat, not because they receive too low loading dose. I don't think so, because we also do multivariate analysis to determine whether poor clinical outcome result from higher BMI or higher body weight or not, but we found only low loading dose as the significant poor prognostic factor. So in my opinion, this is the real information, and I think we need to revise the recommended dose. 1,006 milligram BID may be adequate in some subgroup population, not everyone. So I think to prescribe Favipiravir, we choose based on body weight, not for just the BMI, because some patient may have a good body build like 100 kilogram, but they tall like 6 feet, and their BMI may be below than 35, so they can use exactly the same regimen based on their body weight. Yeah, I'm not sure if I can answer that correctly. Yeah.
Okay,
Okay.
Dr. Maftuha,
May I
your
one
question?
question
Okay.
again?
Mhm.
Yeah. Thank you, Pia, for your answer. And may I ask about the combination therapy? Yeah? So you said before that promising effectiveness of favipiravir in combination with chloroquine or hydrochloroquine and protease inhibitor. Yeah. So I see the presentation is very high regarding compare with other combination, maybe about the azithromycin and other drug. Yeah. So, but we know that many countries still use the azithromycin for the combination. Uh, we don't say about the side effect, but about the potential. How your opinion about this, about the potency and the synergism maybe from the favipiravir and the azithromycin compare with the combination with hydrochloroquine and protease inhibitor.
Okay.
Thank you. Yeah.
So the question is, what do I think about acetaminophen combination to other medication? So,
Yeah.
I think in my personal opinion, I had very bad experience with azithromycin, because I think I took care very sick patient, and all cases who receive azithromycin experience QT prolongation, and it will be very difficult for critical care doctor or our team to monitor both respiratory support and also cardiovascular support. So I prefer to do not use azithromycin at the first. However, in some patient, azithromycin may be needed. In some case, we are not sure whether they have co-infection with other atypical pathogen or not. The symptom may be presented as the mycoplasma infection or legionnaire infection. As we know, viral pneumonia can be combined, can be presented with other kind of pathogen. So sometimes we add macrolide in term of treat atypical pathogen, not for COVID-19 disease. So this is my personal opinion. However, I think many study out there show that azithromycin may be dangerous in term of adverse drug reaction. And based on our national data, we enroll more than 1,000 patients and who receive an antiviral agent in our country, and we found that patients who receive azithromycin or other kind of macrolide experience more adverse drug reaction. However, we are right now we cannot 100% sure that adverse drug reaction came from azithromycin because we cannot do good multivariate analysis. But at the moment, there is no randomized control trial to prove that azithromycin show promising efficacy, but our own experience see that we face a lot of adverse drug reaction. So right now, our national committee decide to remove azithromycin from our CPT.
Oh,
Yeah.
okay. Thank you for your opinion. Thank you, Dr. Arifa. Yeah.
Yes, thank you, Dr. Maktuha. Pinyo, your explanation of azithromycin is very exciting because so far studies has been shown that azithromycin just not only as antibiotic, but as immunomodulator is also effective with COVID-19 patient. I hope you can stay with us until the last session because our last speaker will talk about effectiveness about azithromycin. I think.
Yeah.
I hope so.
Yeah, I will be here till 3. I
Okay.
have another meeting at 3. Yeah.
Okay. Thank you very much. Maybe Dr. Napriardi, can you give a comment or a question for Pinyo?
Okay, thank you very much, Dr. Maktuha. Good afternoon, everybody, and especially for our guest speaker from Thailand. It is a very interesting presentation as you made, and we see some differences between Thailand and Indonesia, but in principle, most of the treatment may be quite the same, but there is a difference in some aspect. I have the impression that you tend to use multiple antiviral therapy. Along with chloroquine, hydrochloroquine, you still use PI and antiretroviral, and last one you test the favipiravir in the same patient. And also maybe azithromycin is still used in your country, although it is recommended not to use anymore. But what I see is that slight different from what we consider in Indonesia. In Indonesia, we consider that azithromycin is okay, and that's why in every step, every degree of security, we use the azithromycin. And even for the severe drug, we don't recommend the use of chloroquine or hydroxychloroquine because we consider maybe the chloroquine or hydroxychloroquine will induce the bronchitis or arrhythmia in severe cases, because in that case, there are many patients who experience the hypoxemia. This is the risk factor for the QT prolongation. My question is about your clinical trial, which is also very, very interesting. You said that maybe loading dose is the risk factor of high mortality. So you propose that the loading dose should be higher and it should be used earlier, isn't it?
Actually, the question is, would I recommend to up the recommended loading dose or not, right?
Yeah,
Yeah,
you
okay.
recommend the higher dose.
So I think based on my opinion, our guideline recommend to use fixed dose 1,600 milligram BID on day 1 for everyone with a BMI less than 35. But if the patient BMI higher than 35, we can use 60 milligram per kilo per day for the loading dose. So I will not recommend the higher loading dose, but I recommend to load the drug based on body weight. We should not use fixed dose for everyone, because some patients who have high body weight but low BMI, they will receive underdose favipiravir therapy. So I think 60 milligram per kilo per day on the first day is adequate if we calculate based on the body weight. The standard dose for influenza in Japan cannot be used for everyone for COVID-19 patient. This is my answer. Yeah. Not sure
Okay.
it's clear or not.
Have you tried to have you tried to normalize the dose with 40 kilogram or 60 kilogram or 80 kilogram, and you have given the same dose? So it means the per kilogram body weight, the patient don't have the same dose. So how you conclude that this lower dose who tend to have higher mortality?
Actually, I did not categorize patient by body weight, but I did categorize patient by BMI because someone say that this is not because low loading dose, it's because they have high BMI, which is a well-known risk factor for severe disease. But in our study, we did not found any significant association between BMI and poor clinical outcome. Only the
Yeah.
low loading dose become significant in multivariate analysis. And
Okay, I suggest if you try to calculate the dose per kilogram body weight, you still find the same phenomenon. It means that the lower dose tend to high mortality. Even the inverse, maybe those who have a low body weight, it means they have the higher dose per kilogram body weight. Maybe it gives the contrary conclusion. We don't know. Yeah, I suggest to try to calculate the dose according to
yeah,
body weight. I mean, you normalize with body weight. Yeah. Okay.
yeah, yeah.
Another question.
Mhm.
Yeah. Please give content for my question.
Yeah. And I personally believe in the dosage based on body weight because I have several patients who weigh over than 100 kilo and like 120, 140 kilo in my ICU. And after use this, but they are really tall, and when we calculate BMI is below 35. So sometimes we use exactly the same dose as recommend, 8 tab every twice a day, and we fail the regimen. So I have to make a call to Thai CDC and ask for the more drug because at the beginning of the outbreak, Fabiravia is very expensive and we cannot find anywhere. And so if we would like to use not recommended dose, use other doses, we have to make a call to Thai CDC every time. And I did that many times for our patient with a high body weight. Yeah. So
Okay.
I try to do the analysis to convince the policymaker to change the recommended dose.
Okay. Okay. Another maybe general question, not directly to your clinical trial. Do you use other drugs such as corticosteroid or heparin, which now popular, become more popular to use heparin? How do you think about it?
Yeah. I heard from my friend in other country that they use heparin or low molecular weight heparin a lot, but those among Caucasian patients, they experience microthrombi and also pulmonary emboli. But in our patient, we do not routinely use anticoagulant. I'm not sure, and our patients are okay right now, but I'm not sure because it's different in genetic or not. I think incident of venous thromboembolism in Asian population may be lower than Caucasian patient. And another one is based on our experience, patient with sick and require mechanical ventilation, they have a very high rate of GI bleeding. I think if we routinely recommend anticoagulant in severe COVID-19 patient, they may do more harm than benefit. This is my own opinion. But we do not put anticoagulant in our guideline.
Okay. Thank you very much. Okay. Okay. Thank you very much. Okay. Thank you, Dr. Mahtuha.
Thank you.
Yeah, you're welcome.
Thank you, Dr. Nafriali, Dr. Pino, for your interactive discussion. There is some question from participant from Dr. Sartono SPPD. Dear Prof. Prof. Pino,
Okay.
Is there any indication of examining the dimer in COVID-19 patient on first day of hospitalization? If suppose the dimer is increased, what medicine do you usually administer to prevent any outcome caused by elevated dimers?
Yeah, okay. So for the D-dimer, we do not routinely check for D-dimer in our country. And as we may know that D-dimer is a proxy of DIC. And I believe that in all severe patient, we have some degree of DIC, and I think everyone will have a high level of D-dimer. But in our country, we recommend to check for CRP, which is widely available in our country, but D-dimer is maybe only available in university hospital. But CRP is a good predictor for severity of illness in COVID-19 patient. And another proxy for severity is procalcitonin. So we recommend in our hospital, not at the national level, we always check procalcitonin to make sure that patient do not our patients do not have superimposed bacterial infection, and if procalcitonin is low, we prefer to use steroid. As I'm not sure if any speaker will talk about steroid or not, but a few weeks ago, we can check for the a large randomized control trial that confirmed that dexamethasone show promising efficacy for patient with severe COVID pneumonia, and that what we exactly do in the past, but we do not use dexamethasone. In our hospital, we use methylprednisolone.
Okay, thank you. I think you would prefer to check procalcitonin
and CRP.
Yes, and CRP. Okay.
Because D-dimer is not available in all hospitals.
Yes. Okay. There is a question from two question from Hazel Chandra. Why we don't use remdesivir instead of favipiravir? And the second question is, can we use the combination of fondaparinux, azithromycin, and remdesivir for COVID-19 medication? There is two question Pinyo from Hazel Chandra.
Okay, so the first one, actually, I believe that remdesivir is a very good drug, and it is the drug that show promising efficacy in 3 large randomized control trial. If I have a limited amount of remdesivir, I will prescribe this to everyone with pneumonia. But however, right now we got just for, I think we got a stock of remdesivir for just 100 cases. So it's a limited amount in our country. So we cannot let this drug to prescribe for any pneumonia patient. So right now, clinical practice guideline still limit the remdesivir for patient who cannot orally take for Faviravia. But I agree with you, remdesivir should be the drug of choice, should be the first line drug for all patients with pneumonia based on evidence we have right now. However, currently Thailand is working with Japan pharmaceutical company to conduct a large trial to evaluate the efficacy of Favipiravir or treatment of COVID-19. So I think the result will come at the end of this year, and we can see whether remdesivir or Favipiravir, which one is better. And for the second question,
the combination of fondaparinux, azithromycin, and remdesivir.
So as I mentioned before, we do not prefer fondaparinux and azithromycin. So I think if they have additional indication for fondaparinux and azithromycin, we can use in conjunction with remdesivir. But I cannot say that my knowledge is 100% correct because I have no experience as all on remdesivir. It's just available in our country for maybe 2 weeks. I have never used that.
Thank you, Pio, for your clear understanding. So I welcome Dr. Annette to ask question. Please, Dr. Annette. Yeah, Dr. Annette.
Thank you, Prof. Pino, for your explanation. Have you ever tried, because in Indonesia, we use oseltamivir in the beginning before we use favipiravir. Whether in Thailand, do you have any experience using the oseltamivir?
Yeah, in the early phase of outbreak, we also use oseltamivir, but based on in vitro mechanism, I don't think oseltamivir gonna work. So as we see that we have many antiviral with in vitro activity, but when we conduct clinical trial, it do not work. So I don't think any antiviral agent without in vitro activity would be work in the clinical study. So right now we do not recommend oseltamivir.
Okay, because
Unless you think that the patient may have co-infection with influenza.
Okay, because in Indonesia we still in clinical practice some still use the oseltamivir until now.
Yeah.
Maybe that is one of the factor that the recovery rate in Thailand is 95%, right? From
95% for pneumonia patient who do
okay.
not require oxygenation.
Oh, okay. Okay, I see.
So not overall patient, but pneumonia patient.
Okay.
So as I know, COVID-19, SARS-CoV-2 do not have neuraminidase enzyme. So I don't think neuraminidase inhibitor would be work in COVID-19.
Okay.
Yeah.
Okay, Achan.
Okay, thank you.
Thank you very much, Achan.
Another question, Dr. Annette? Another question? You have another question?
Okay, so for the one that Dr. Nafrialdi already said that in Indonesia, the hydroxychloroquine caused the QT prolonged. But in your experience, the one that caused QT prolonged, in your opinion, is the azithromycin, not the hydroxychloroquine.
Yep.
Am I correct?
Yes. I'm not sure if you use the exactly same dose as in our country or not. What is the dose of hydroxychloroquine that you use in our country?
I'm not sure. I think it's around 200 milligram. Yes.
Per day?
Yes.
Oh, okay. Because we use a higher dose than that. We usually use like 4 tab per day. So 250 milligram tab of hydroxychloroquine, which equal to 200 chloroquine base. So I think we use nearly 1,000 milligram per day, and we do not experience any QT prolongation. But this is based on my own bias because we will prescribe 3 drugs in a patient with risk factor. So patient who receive only hydroxychloroquine and protease inhibitor will be more healthier, maybe healthier than patient who receive hydroxychloroquine, protease inhibitor, and azithromycin. So nearly all of patients who have QT prolonged receive azithromycin. That may be a significant bias toward my conclusion.
Okay, Achanka. Maybe for the dose, I'm wrong because I'm not a clinician. Maybe my friend know better than me for the dose of the hydroxychloroquine.
We use loading dose 4 tablets on the first day and then 2 tablets on the next day. And it's nearly 1,000 milligram on the first day. Yeah.
Okay, Achanka. So it's there is no confirmation about the QT interval is caused by the azithromycin or or because of the hydroxychloroquine. Okay, thank you very much.
And I think QT prolong is common among sicker patients because they receive combination therapy, especially lopinavir, ritonavir. I'm not sure if you use lopinavir in your country or not. And nearly all of them develop diarrhea, and when they develop diarrhea, they have hypokalemia, and hypomagnesemia. So this will potentiate the side effect of azithromycin. So I don't think it's the caused by azithromycin itself. If you use azithromycin monotherapy, I don't think you're gonna have a problem with QT prolongation. But because we use combination therapy, we experience a lot of QT prolongation patient, 5% in our study.
Okay, Achanka. Thank you, Achan.
Okay, thank you,
Yes.
Dr. Annette. There are another question, Prof. Pino from Suharjono. Why favipiravir cause diarrhea? And do you monitor biomarker like viral loads, troponin?
Monitor what? Can you say it again?
Why favipiravir cause diarrhea?
Oh,
And
okay.
also, do you monitor biomarker like viral load, CRP and troponin in your research?
So the lab monitoring, we do not routinely recommend, but we usually recommend to monitor electrolyte at least twice a week, not because favipiravir, but because lopinavir, ritonavir, because it's caused diarrhea. But for the cost, right now, one tablet of favipiravir is 50 baht, which equivalent to 50 baht is less than $2 per day per tablet. But we use, let me calculate, we use 8 tablet twice a day on the first day and 3 tablets twice a day on the next day. So it would cost approximately $20, $20 on the first day and $10 on the second day and afterward. But this is the price from the Fuji film. The it's an original drug Avigan from the Japan. Right now, I heard that India pharmaceutical company can make favipiravir. So I think the drug will become cheaper and cheaper and available widely worldwide. Yeah.
Okay, thank you, Pio.
Total
The
cost maybe
last question from
100
Muhammad.
USD.
Okay, thank you. Last question. The last question, Dr. Muhammad Korib, SPFKR. Please, Dr. Muhammad Korib, SPKFR, please ask your question.
Thank you, Dr. Arifa, for the time. And I think it's a very interesting presentation and interesting discussion. I have a question, and I just need a suggestion from Professor Pino. Professor Pino, based on your experience, is there any prerequisite or pre-requirement before you giving favipiravir?
Okay. Actually, I think that the problem of favipiravir, I do not experience any severe adverse drug reaction based on favipiravir itself, but because we use in combination with other medication, we always monitor EKG and electrolyte because we're afraid of drug interaction that may cause QT prolongation and hypokalemia. However, because these patients are very severe patient and we do monitor other parameter nearly every day. But in my own personal experience, favipiravir is quite safe for itself, but it may not safe when combined with other medications.
Is there any worsened side effect have been recorded, Professor?
Yeah, I think the most common side effect that they report in other study is hepatitis, and also the most common one is GI side effect, and the lethal side effect, the next lethal side effect may be hepatitis. But in our series, we experience hepatitis just for 7%, I guess, but not all of them are my hepatitis. No lethal adverse event recorded.
Do you have any suggestion to prevent the side effect?
To prevent the side effect, I think because we do not know what is the best dosing, so I think we should use not too low and not too high dose for favipiravir, and uh, we can do the best by avoiding other hepatotoxic drug, which in our regimen there are many drugs that can cause hepatitis, including protease inhibitor, hydroxychloroquine can cause hepatitis, and also azithromycin can cause hepatitis. But someone may not know tocilizumab. I'm not sure if you use tocilizumab in your country or not. Tocilizumab is the important drug that can cause hepatitis because we experience one severe hepatitis from tocilizumab, and the patient nearly require liver dialysis, but because they are young and the liver they can recover after that. Yeah. So the best way to avoid side effect is avoid other hepatotoxicity. Yeah.
Thank you for your explanation, Professor. Thank you, Dr. Arifa.
Okay. Okay, thank you, Dr. Muhammad Korib. Unfortunately, time has run out. I apologize for all participants that your question has not been answered with Spino. But I hope we can continue our collaboration in the future.
Yeah.
As an appreciation from the committee, there was a certificate for Associate Professor Joanna Ampawan.
Thank you so much.
This is the certificate for you, Prof. Pino. Prof. Pino, thank you very much for your sharing, and I hope you will stay with us until 3 p.m.
Yeah.
Okay. Thank you, the AWCS team. Briefly, I would like to invite our distinguished speaker, Dr. Diana, SPFK, clinical pharmacologist from RSUP Persahabatan Jakarta. The topic that she would like to present it is the roles of anticoagulant treatment for COVID-19 patients. Presentation time is 30 minutes. Dr. Diliana, SPFK, time it's yours.
Thank you for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. Today I'm gonna talk about the role of the anticoagulation treatment for COVID-19 patients. I'll try to share the screen first. Okay. Ya, ini lagi slideshow. Bismillahirrahmanirrahim. Damn it. Okay. Okay, I will start my presentation. My presentation is the roles of the anticoagulation treatment for COVID-19 patients, which we can talk about the complication of COVID-19, the virology of SARS-CoV-2, the clinical course of COVID-19, the coagulation abnormalities, the treatment, and the PK/PD of anticoagulant. As we all know that novel coronavirus designed the severe acute respiratory syndrome coronavirus 2, known as SARS-CoV-2. The disease emerged in late December 2019 from a cluster of pneumonia cases known as COVID-19. From since the outbreak of COVID-19 on December 20, 2019, the prognosis become worse. The clinical course of COVID-19 up to 15% usually involve the interstitial pneumonia evolving toward acute respiratory distress syndrome and then leading to the mechanical ventilation or admission to the ICU. And the the symptoms are also, usually often accompanied by multiple organ failure. The SARS-CoV-2 is an envelope positive sense of RNA virus. This novel coronavirus has the same family as SARS-CoV and Middle East respiratory syndrome coronavirus. I have some studies here. The first study report that 41 patients hospitalized as confirmed COVID-19 patients shows the laboratory findings of D-dimer values were increased nearly fivefold higher. And then Tang et al. Observed 183 patients with COVID-19 um, have the D-dimer value increasing nearly 3.5-fold higher. Another study of 138 patients shows the D-dimer values increasing nearly 2.5-fold higher. And the third study of 191 patients with COVID-19, the D-dimer values increasing nearly ninefold higher in patients who died. The critical condition happens in 5% cases, which the symptoms are respiratory failure, pneumonia, shock, multi-organ failure, and death. The death usually involve the acute respiratory distress syndrome and multi-organ failure. As we all know, the incubation period between contact and the first set of symptoms is typically 1 until 14 days, but it can be up to 24 days in individual case. Now, I have a figure of symptoms and biochemical and radiological features of the COVID-19. From mild to moderate, the symptoms are fever, dry cough, fatigue, nasal congestion, rhinorrhea, sore throat, myalgia. And the laboratory findings, we can see that the leukocyte is low or normal. And the hepatic marker like ALT and AST is high. The mild and the mild stage the mild stage symptoms appear in the first 3 until 7 days. And the moderate symptoms appear after 7 days of the symptoms. And then when the disease become worse, become severe, we can see the symptoms like shortness of breath, dyspnea, the low of the oxygen saturation, usually not more than 94% at rest. And the respiratory rate is more than 30 times per minute. And we can see that when the symptoms of ARDS, septic shock, metabolic acidosis, DIC, myocardial injury, and myocarditis, the laboratory findings shows the troponin I is high, the CRP and ESR D-dimer is increasing, and the lymphocyte is decreasing. and the inflammatory markers like interleukin 6 and TNF alpha is elevated, but the procalcitonin usually normal. Um, when this happens, we can conclude that the patient suffer from sepsis and lead to multiple organ failure. At this stage, usually from the chest CT scan, we can see the multiple ground glass appearance and the infiltrate are filling the hemithorax. And sometimes we can see that there is a pleural effusion. Here is the clinical course of COVID-19 where the virus invade the peripheral vessels and get into the lung and the heart. And in the heart, the virus cause inflammation that involve the T cell and macrophage. And then when the cytokine storm happens, the interleukin 6 and interleukin 7, interleukin 22, and CXCL10 is increasing. And the clinical course in the heart, uh, the virus can cause the myocarditis that lead to heart failure and finally can meet the acute coronary syndrome too. Um, when the myocardial damage happen, we can see that troponin I, CK, and LDH is increasing, and the damage of the myocardial can lead to arrhythmia. Here is the figure of pathophysiology of coagulation disorder, where the cytokine storm invade the hyaline membrane. Here is the DIC, which is a complication that we are so scared about, which can be observed in 71.4 of non-survivors, where we can see that there is a massive pulmonary embolism. And the Chinese and the Thailand experience that the D-dimer levels can be observed earlier. Now, I have some reports about the COVID-19 patients that the the laboratory findings also shows the thrombocytopenia in 36.2% cases, and then elevated of D-dimers and prolongation of PT-APTT compared to survivors. 71.4% PT-APTT prolongation happens for non-survivors. And survivors also can suffer of prolongation of PT-APTT in 0.6% cases. And the DIC happens in 8% cases. These factors associated with poor prognosis in patients with COVID-19. In this figure, I want to talk about that the anticoagulant and antiplatelet works here to avoid the thrombosis. Now we can see that the platelets, when they activated, they form a thrombosis and then can lead to ARDS, cardiomyopathy, acute kidney injury, stroke, and diarrhea. Now the treatment. The recommendation for the D-dimer elevation is anticoagulation therapy. When the D-dimer value is 4 times higher than normal, we can start to use anticoagulation. Because the D-dimer increasing can cause inflammation and other disease-related factors that cause overactivation of coagulation. That means increasing the death risk. And in Italian Society of Infective and Tropical Disease recommends that antiviral agents can be used in mild symptoms, but in moderate to severe symptoms, uh, they recommend that antiviral should be avoided. Here is the drug therapy of for COVID-19. The recommendation is low molecular weight heparin is more recommended than unfractioned heparin. And for the study I read here that 28-day mortality of the patients who received low molecular weight heparin is um, giving more better prognosis than the unfractioned heparin. Here is the graphic uh, where we can see that for heparin users, the 28-day mortality is very low compared to heparin non-users. I have an example of patient with uh, COVID-19 when the disease progressivity um, shows the D-dimer level, the D-dimer level is increasing. And then at this time, the unfractioned heparin administered, and then it leads the D-dimer decreasing. And after the patient discharge, the D-dimer is more and more decreasing. And another patient have had a low molecular weight heparin, enoxaparin here, and the dosage it was 70 milligrams twice a day subcutaneously. The D-dimer over 2000 can decrease uh, day by day um, until around 10,000. And I have a data about the COVID-19 patient in June 2020 in Persahabatan Hospital that the risk of sepsis take place, the first place of complication, which is 21 patient suffer from sepsis. And cardiovascular risk happens in 17 patients, and the D-dimer uh, increase more than 10,000 happens in 31 patients, and the PT prolongation usually not more than uh, 2 times from control. Now, the question is, what if there is bleeding risk? The patient with COVID-19 is, uh, is in a high risk of venous thromboembolism or VTE. The patients with VTE had poorer outcomes than patients with a low risk of VTE. Then, um, so, but if we have identified that this patient have COVID-19 with high risk of VTE, so the patient should be administered the prophylaxis of anticoagulant. And but the patients who suffer VTE also had a high risk of bleeding. That's why we have to adjust the dose and the duration of anticoagulation. Here are the contraindication of anticoagulant, where the platelet count is not more than 25,000 and the patient receiving anticoagulation for other reason, patient considered to be at high risk bleeding, patient with trauma with high-risk bleeding, active bleeding, heparin-induced thrombocytopenia, acute stroke, the procedure within 12 hours like surgery or lumbar puncture, and acute bacterial endocarditis, hypertension, and liver failure. So, another question, should seriously ill COVID-19 patient receive therapeutic intensity anticoagulation empirically even the VTE is not um, found? Well, the answer is the microvascular thrombosis is hypothesized to be involved in hypoxemic respiratory failure in some patients with COVID-19. So, consequently, we should recommend the anticoagulant therapy for critically ill patients, especially characterized by very high level of D-dimer, abnormal coagulation parameters, markedly elevated inflammatory markers, and multi-organ failure. Here is three strategies that we can do to give anticoagulant in the ICU patients. For patients haven't who hasn't the DVT or PE, then we can give the anticoagulation for thromboprophylaxis. We can give low molecular weight heparin 40 milligrams per day or subcutaneously heparin 5,000 units per day. And if the patient suffer from DVT or PE, the, the anticoagulation should be given full dose, where the dose is 1.5 milligram per kilogram per day, and uh, also oral anticoagulant with standard dose. And the patients who, um, and the third strategy is a low dose anticoagulation protocols, where heparin administration is for the acute coronary syndrome and atrial fibrillation. We want the target of the coagulation factor 10A reach 0.2 until zero point 0.5. Here is where the anticoagulant um, work. The drug work in an exchange factor, especially in 10A factor. Now we can see that the factors, the coagulation factors, where the heparin work is in is at 9A, 10A, 2A, and the oral anticoagulant factors works in factors 7, 9, 10, and 2. Now we can see that various anticoagulants, which one we can choose. Um, we can choose according to the targets. If the target is vitamin K epoxy reductase, so the administration can be oral. The drugs are warfarin and tecarfarin. And if you want to target in factor 2 orally, we can give C-melagatran and dabigatran. And for the factor 10A, we can use the oral preparation or subcutaneous preparation. The oral are apixaban, rivaroxaban, edoxaban, betrixaban, and subcutaneous uh, drugs are idraparinux, idrabiotaparinux, enoxaparin, dalteparin, tinzaparin. Um, Now, the low molecular heparins is more recommended than unfractionated heparin because it gives a better prognosis for the patients, especially for COVID-19 patients with D-dimer elevation. When do we monitor the heparin effect? Usually, the heparin effects are bleeding. Um, the laboratory findings that we can check is APTT. And here comes the summary. So the laboratory testing is not needed for the non-hospitalized patient with COVID-19, but the hospitalized patient should be test for the D-dimer, prothrombin time, platelet count, and fibrinogen as a coagulation parameters. And the patients who have consumed anticoagulant and antiplatelet for years, they should continue the medication even they have uh, the COVID-19 um, disease. And the treatment of COVID-19 with thromboembolic event for non-hospitalized patients, we can use anticoagulant or antiplatelet therapy. Um, but not for the, we cannot give the anticoagulant and antiplatelet therapy, but the hospitalized patients we should give because the risk of VTE and DIC and the high of the D-dimer level. Thank you for the presentation and the opportunity. I give the time for the moderator.
Thank you. Thank you, Dr. Diliana, for your informative presentation. I've been made several highlights about your presentation. The dimer is an important parameter to start anticoagulant treatment. So the anticoagulant treatment in the COVID-19 patient can reduce the dimer level, and the dimer level correlates with the clinical symptom and sign of the IC.
Yes.
Okay. The last speaker, but not lastly, I welcome Dr. Abdul Khairul Rizki Purba, SPFK, MSc, PhD, from Faculty of Medicine, Universitas Airlangga. The title of his presentation is the clinical pharmacology aspects of azithromycin and COVID-19 treatment. I think it's interesting topic and correlates with the topic of our first presentation from Prof. Pino Ratana Ampawan. And I hope we could develop a wonderful discussion about this. Dr. AKE Purba, the stage is yours.
Okay, thank you very much, Dr. Arifa. I will share my presentation. Yes. Okay, could you see my PowerPoint? Okay, I hope so.
Yes, I can see your PowerPoint clearly.
Sure. Thank you. Okay, Bismillahirrahmanirrahim. Thank you. First of all, I would like to thank the committee of Erlangga webinar conference series and Department of Pharmacology, Faculty of Medicine, Universitas Erlangga to perform this very fruitful event, even we do this virtually webinar. I'm grateful today to have sharing knowledge and further discussions with each other about therapeutic in COVID-19. And let's start. Yeah, in this presentation, there is no conflict of interest to declare. Okay. Yeah. And this morning, I got coronavirus metrics from WHO, and globally, there were about 24 million confirmed positive cases with COVID-19. And the mortality rate reached 800,000. It's very huge, it's very high. And what about in Indonesia? Indonesia, there were 160 hundreds. It's about 0.67%. It's very small number, but it's very clinical significance for us. And the mortality rate reached 7,000 or about 0.85% compared to worldwide numbers. Okay. Currently, there are several guidelines for the treatment for COVID-19 patients, and hydroxychloroquine sulfate, 200 milligrams three times daily for 10 days, plus azithromycin. It's common use a combination with azithromycin, 500 milligrams for 1 day, followed by 250 milligrams once daily for 4 days. And but some studies not use hydroxychloroquine or chloroquine. When we compare to hydroxychloroquine or chloroquine, that is some centers not use it. Azithromycin is globally taken into account in most guidelines up to now. It is because multiple reports demonstrate that concomitant use of hydroxychloroquine and azithromycin can prolong QT interval. And in some observational studies, HQ or hydroxychloroquine plus azithromycin was associated with increased odds of cardiac arrest. What about the guideline in Indonesia? Guidelines for the treatment of COVID-19. Patients with asymptomatic, there's no azithromycin available, just only vitamin C, 500 milligrams twice a day. And for mild patients, they give, or the physicians gives azithromycin per oral, 500 milligrams once a day in 5 days. And yeah, commonly combined with chloroquine phosphate, 500 milligrams twice a day for 5 days. And hydroxychloroquine, we know that one tablet is 200 milligrams, so we give 2 tablets, 400 milligrams once daily, per oral, 5 days. And patients with moderate or severe symptom, we give in the guideline, based on the guideline, azithromycin per oral or injection 500 milligrams per 24 hours or once daily in 5 to 7 days. And we combine with chloroquine phosphate, 500 milligrams twice a day for 5 until 7 days, and hydroxychloroquine, one tablet, we know that 200 milligrams. Yeah, we give 5 in the first day, we give 400 milligrams, 2 tablets. So 4 tablets in the first day, and then the second and until 5 to 7 day, we give 400 milligrams once daily per oral. Okay, azithromycin. When we talk about the drugs, we have to know about the pathophysiology or pharmacodynamics, the drugs. Some study show that there are 3 properties of azithromycin in the treatment for COVID-19, especially for this case. There are antimicrobial uses and for antiviral properties and immunomodulating agents. I will explain one by one. First is antimicrobial use. The clinician use this as antibacterial because there is a potential impact of this COVID-19 is the secondary bacterial infections and cell loss. We know that there is an impaired innate and adaptive immune response. Viral infections impair the phagocyte functions and induce alveolar macrophage, and depletion results in the facilitation of bacterial infections via apoptosis of the macrophages, and then virus induced dysregulation of pro-inflammatory cytokine response played a major role in promoting secondary bacterial infections. And here we can see that the type 1 interferons are well reported for antiviral and immunostimulating properties. Inappropriate or excessive protections might have harmful effects. And then epithelial cells of the respiratory tract facilitate bacterial adherence and colonization using different mechanisms during viral infections. And it can enhance bacterial permeability to the epithelial monolayer and supplementing attachment to the host cell receptor. And then Respiratory viruses like COVID-19 are often encourage secondary bacterial infections by supplementing the outgrowth opportunistic bacterial pathogens in the hospital, and then the viral infections damage the respiratory airway, both histologically and functionally pathology. And in the there is a study uh, about 24 studies. It is about a meta-analysis representing 3,300 patients with COVID-19 evaluated for acute bacterial infections. And bacterial infections was more common in critical ill. We can see here it's about 8%. The majority of patients with COVID-19 receive antibiotics is about here, about 72%. It's very high. The incidence bacterial infections in critical ills is about 8% and overall is 6%, but the antibiotic use is about 7%. Okay. As you know that here uh, in the study, 30 study include in the same study with a little evidence of Staphylococcus aureus or Staphylococcus pneumoniae, or yeah, we know that that is the very common pathogens. We can find it in the patients with pneumonia. But here for COVID-19, 40% from out of 3,800 patients, 40% is infected by Mycoplasma pneumonia. So yeah, this is an atypical pathogen in pulmonary or respiratory tract. And the evidence said that this is the preliminary results about early administered antibiotics that do not impact mortality in critical ill patients with COVID-19. But this is very, very low number of patients included in this analysis. So yes, we have to do the investigation for the future about give antibiotic or not in critical ill. Okay, for the second one, it's about antiviral properties. There are some proposed models, and this is about possible role of mechanism that explain synergistic effect of azithromycin, and then might be combination with hydrochloroquine. And yeah, from the in vitro study, there is ABCB, or ATP binding cassette family B member 1, or ABCB1. This is a multi-drug resistant protein, or MDR1. We know that here, as a substrate of this transport, the active uptake of azithromycin contribute to the enhancement of these trapping effects and to the neutralizing to the acid pH in the endosome. And from this endosome, this is can make an acidic environment of the lysosome. The equilibrium between charged and uncharged drug species shift in favor of the ionized species, thus limiting their backward diffusion into the cytosol. And this is can cut off the cycle of virus, because the drugs can be can come into the lysosome and high concentration in endosome and make high increase the macrophage activity. Okay, for immunomodulating effects, yep. Beyond the simple bacteriostatic function of azithromycin, this is a good study about immunomodulating activity, and then these effects can be described as an acute phase of inhibition of inflammation and late phase of resolution of chronic inflammation. And this cytokine severe to signal neutrophil and macrophages and other phagocyte cells to the site of inflammation. In the late phase, azithromycin has been shown to decrease the oxidative force of neutrophil killing and increase neutrophil apoptosis. Azithromycin diminishes T helper 1 cells or T helper 1 response following lipopolysaccharide activation of alveolar macrophage, and largely through modulation of the pro-inflammatory cytokine signal already described. And then azithromycin roles in the process can be explained by its inhibition of the transcription factor, nuclear factor kappa beta here, and then which function to activate transcription of many pro-inflammatory cytokines, including interleukin 8. Thus, the many immunomodulating effects of azithromycin treatment severe to reduce acute inflammation and to promote long-term healing and repair. And then in the early, azithromycin mainly stimulate effect and neutrophil, probably mediated by interaction with phospholipid and ARK1 or ARK2, followed by later modulation of transcription factor AP1 or NF-kappa beta, and subsequent delayed inhibitory effects on the cell function are likely related to lysosomal accumulation of the macrolide with disruption of protein and lipid transport. And then, yeah, azithromycin, this is the drug bind to the 50 subunit of ribosome. And the concentration and time-dependent killing, this is broad spectrum antimicrobial, and they have activity to against atypical infections. And macrolide antibiotics are significant inhibitors of CYP3A4 and have several interactions via these pathways. But for azithromycin, it is azithromycin has less activity on CYP3A4 and has weaker drug interactions. But some studies say that there is big pharmacodynamic drug-drug interaction. And azithromycin distributes readily into most tissues, and we know that a volume distribution is about 31 liter per kilograms, and for clearance, it is a hepatic clearance. Okay, when we see here, azithromycin is rapidly absorbed following oral administration, has a long serum half-life. It's about 68 hours, and large volume of distribution, it's about 31 liters per kilograms. Azithromycin is taken up by leukocyte at concentration that are about 300-fold higher. So it's very, very high than plasma. And in affected tissue, azithromycin concentration are higher than in plasma due to recruitment of leukocytes at the site of infections. And then we can see here this present how wide the drugs reach the body compartment and during and after a 3-day regimen, 500 milligrams daily for 3 consecutive days in healthy volunteers. In muscles, the azithromycin concentration is very higher than in the plasma, but in the white blood cells, the concentration is very, very high. The study saw that the data in day 2, this is day 2, it reached 200 nanograms per milliliter in patients with 500 milligrams per day dose, and 4,000 nanogram per milliliters in patients with administration of azithromycin in day 3. So it's very high in white blood cells. And if we correlate with the findings of mycoplasma pneumonia in COVID-19, in vitro antimycoplasma activities of 8 agents, this one against 50 isolates of mycoplasma pneumonia, the MIC macrolides resistant this one, yeah, it's very, this is a resistance is very high, 16 and 128, and we know that it's not sufficient to estimation against this resistant organism, but for sensitive, they can do it. Okay, clinical significant drug-drug interactions. It's about more um, the involvement of azithromycins um, during using combination with hydrochloroquine or chloroquine. This is pharmacodynamic interactions. Yeah, we know that um, it can cause arrhythmias or cardiac arrest, and also oseltamivir and anti-arrhythmias like digoxins, and then ivermectin and albendazole and diethylcarbamazine. There is no pharmacokinetic interactions, and there is no pharmacodynamic interactions in some studies. And then for warfarin, this is very minimal, so be careful for bleeding outcomes. Okay, among first study, this investigated hydroxychloroquine and azithromycin as a treatment of COVID-19. This is open label, non-randomized clinical trial and percentage of patients with PCR positive nasopharyngeal samples from patients with first day 3 to day 6 follow-up. And in COVID-19 patients treated with hydroxychloroquine and azithromycin combinations, we can see here from 5 out of 6 to, and all patients are recovered in the day 6. So it is very nice results, but the sample size is very small. And then we know that New York study, it's about 50,000 patients involved in this study. This is a retrospective multi-center cohort study, and then involved 25 hospitals. A greater proportion of patients receiving hydroxychloroquine and azithromycin is about 735. It's very big numbers when we compare with other arms. This is so that the cardiac arrest was more likely in patients receiving combination hydroxychloroquine and azithromycin with adjusted, we can see here, this one, adjusted ratio is 2.13, and but not hydroxychloroquine alone or azithromycin alone. There is no statistically significant. And then patient taking hydroxychloroquine alone versus azithromycin alone, say that this one, there is statistically significant difference. It's about 3 times cardiac arrest in patients with hydroxychloroquine alone when we compare with azithromycin alone. And then from this model, estimated direct adjusted mortality at 21 days mortality, there is about 17% with hydroxychloroquine alone. This one, this is hydroxychloroquine alone, this one, 70%, and azithromycin alone is about 10%. It's very low when we compare to hydroxychloroquine alone. But there is no statistically different between two arms. Okay, from my presentations, I would like to conclude there are 3 properties of azithromycins as antibacterial, antiviral, and immunomodulating agents, and there is no clear that evidence for azithromycins may exert beneficial effects in COVID-19 beyond antibacterial activity. In COVID-19 infections, empirical broad spectrum activity therapy should be considered, might be chosen only to treat superinfection. And the erythemogenic potential of azithromycin is lower as compared with other macrolides or other antibacterial drug classes, and the use of drugs with even a low risk of arrhythmia with other potential QT prolonged drugs such as hydroxychloroquine or chloroquine warrants close electrocardiogram monitoring. I think that is my presentation. Thank you very much, and I return back the floor to moderator. Sorry, Dr. Arifa. You're still speaking.
Yeah, okay. Thank you, Dr. AKR Purba, for your wonderful presentation. Uh, According to your presentation, azithromycin has several activities such as antibiotic, antiviral, and immunomodulator, but there is not yet a solid evidence that azithromycin uh, has an advantage in the management of COVID-19 patients. I think this is your point of view for your presentation. My honorable participants, I'm sure that you are very impressed with the exposure of all the speakers. And of course, that you have a lot of questions to the speakers, but I beg your pardon that I would like to seek the opinion from our panelists first. I would like to welcome Dr. Maftuhah Romanti, Dr. Magister Kesehatan. What is your opinion or your comment about overall topic in this afternoon? Please, Dr. Maftuhah.
Okay. Thank you, Dr. Arifa, for the opportunity. Thank you too for the Dr. Diliana and Dr. Khairul Purba for your presentation. So I have several questions for all of you, especially for the Dr. Diliana. So in your presentation, the dimer is the important indicator, yeah, for COVID-19, especially might be can prevent severe disease if we check it in the early stage. So in your presentation, there is in the previous study, there is the data that the D-dimer values were nearly 2.5 or 3.5-fold higher in those with severe disease, and nearly 9-fold higher in patients who died. So in your recommendation for patients in the early stage COVID-19, so you recommend that we can use the heparin for it, and I think the requirement is the D-dimer value is 4 times, yeah, 4 times higher than normal. So maybe you have some the data or evidence based from the previous study about the 4 times. So I highlight about the 4 times before, because I saw in some clinician give the heparin, in the early stage COVID-19, even though there is no increase 4 times, maybe 2 times. And well, what do you think about it? So because this heparin actually have some side effect, yeah, for all the patient. There is for Dr. Diliana, and about and for the Dr. Khairul Purba. Thank you for your presentation about the azithromycin. So maybe would you like to give the information again that use of azithromycin is in the COVID-19, yeah? Is it for the antibacterial because the secondary infection of COVID-19, or for the immunomodulator effect that will be benefit for the treatment of COVID-19, or maybe you have some opinion that there is some antiviral activity about the of the azithromycin. Maybe you can give us your opinion. And the second for Dr. Khairul about the Pinyo research result about the combination of favipiravir not to potential with the azithromycin then other combination. What your opinion about it? Thank you for all. Thank you, Dr. Arifa.
Thank you, Dr. Maftuha. Would you like to prefer answer first, Dr. Deliana or Dr. Purba? Maybe Dr. Deliana first.
Okay, I will try to answer the question for the heparin administration. According to the ISTH recommendation, the thromboembolism, even the D dimer is not reaching twofold from normal, heparin should be administered. This administration of heparin is not related to the COVID-19 only because the D dimer is increasing. And for the COVID-19, many research shows that the D dimer is elevating. So the administration of heparin is recommended for the COVID-19 patients. That's my answer.
Okay, Dr. Deliana. Maybe I would like to seek the opinion about the answer from Dr. Purba. Please, Dr. Purba.
Yeah, thank you very much for the question. There are some properties from azithromycin. We know that as antibacterial and antiviral and immunomodulating for the patients with COVID-19. I think that the patients, the life-threatening events is cardiac arrest, and then the cytokine storm. So the import to me the important aspect of azithromycin is immunomodulating effects. For antiviral, maybe we still use antiviral like oseltamivir, or like in Indonesia we use Avigan. Yeah, for azithromycin, from this case, immunomodulating effects is very important. And the second one might be antibacterial, what I explained at the first presentations. Antibacterial is very important for this case because mycoplasma and pneumonia is atypical pathogen that infected these patients. And then the second questions is about, I don't get it, sorry.
The combination. Yeah, sorry. Yes, the combination antiviral, so especially maybe favipiravir or oseltamivir and other antiviral with the azithromycin. So what do you opinion about this compare with the Pinyo result study about that this combination not too potential compare with others?
Yeah. Some studies said that antiviral with azithromycin it's not different with when we use only antiviral. Yeah, it is still need more investigation about maybe sample size. Maybe we can do this from RCT design, maybe, yeah. And then in my PowerPoint, we have to consider arrhythmia when we combine azithromycin and oseltamivir, and I don't get the evidence about azithromycin combination with other in terms of safety. Yeah.
Okay. It's enough, Dr. Makuka?
Thank you.
Oh, thank you. Furthermore, I would like to listen, we would like to listen a point of view from Dr. Nafrialdi, SPFK, SPPD, PhD, clinical pharmacologist and internist from RSCM and FKUI. Please, Dr. Nafrialdi.
Okay, thank you, Dr. Arifah. Thank you, Dr. Liliana and Dr. Khairul for the nice presentation. It's very interesting to comment about your presentation. Maybe I don't have much question about this presentation, but because it is interesting to see the phenomenon we have in recent days that many physicians pay attention, much attention to using anticoagulant therapy for such as heparin. But we know that heparin is the two-sided blade, two-sided knife. And in one aspect, we see that maybe the mortality of the COVID is due to DIC, which involves the coagulation in organ. In that case, we need heparin. But we also see that in severe condition, the risk of bleeding is quite high. So it is very, very difficult to make a decision when to start and when not to start the heparin. Dr. Riana have given some clue. For example, the value of the dimer when to start the heparin and when not to use. But I see that the limitation of, for example, platelet count below 25,000 is very, very low, I think. Maybe clinicians don't dare to give the heparin when the patient, for example, have platelet count of 40,000 is considered very, very low. But at the same time, we also know that in DIC cases, there must be the thrombocytopenia is the one of the symptom of the DIC. And in the case, and even the bleeding is one of manifestation of DIC. In that condition, we still consider that the use of heparin is still logical because even though there is a high risk of bleeding and there is a high thrombocytopenia, but by giving the heparin and when the condition is improving, normally the platelet count will increase and the bleeding will reduce. Even though we give the heparin because the phenomenon is we stop the mechanism of the coagulation in this condition. But I advise the not advise. I think that we have to consider or to evaluate whether this recommendation is applicable for our patient, because we see that in clinical practice, many doctors start at very beginning, even though they have not high daily dimer, they consider that it is a prophylactic drug, which we consider it is not correct to use it as routine prophylaxis. But we still have to see when the condition is deteriorate, it's time to measure the dimer. And when the diamond is increased and the platelet count is not very low, we can start. And there is no bleeding, even maybe minor bleeding if there is exist, we may still use the heparin. But when the platelet count very low and there is a significant bleeding, of course we don't use it. And considering the presentation of Dr. Khairul, I impressed about the phenomenon that about 40% more of the patient have the mycoplasma pneumonia, which is quite high. So I think it is the reason why in almost symptomatic patient the physician use the azithromycin, and it is agreed in the Indonesian guideline to use azithromycin in every symptomatic patient from mild to severe. But and also we see that the interesting phenomenon is that the concentration of azithromycin is very, very high intracellularly. It's maybe hundreds higher than the in plasma. It's very good to use this drug when there is infection. But we don't know whether it is applicable for the virus itself because we don't have the method to witness that this drug is efficacious for the viral infection, not for the secondary infection. Because we use multiple antiviral azithromycin, supposed it is have the antiviral effect, but at the same time we also use the antiviral drug. Even we use the chloroquine, which is also hypothesized to be antiviral effect. So that's the very difficult thing to assess whether one drug is effective for virus treatment, because we don't use single drug for the virus, because when we use 2 or 3 drugs which is supposed to work on viral, it's become very, very difficult to see if there is effective for the virus itself. And however, by looking at the safety profile, we see that when we use azithromycin alone, the risk of arrhythmia or cardiac problem is
Terima
very,
kasih
very
Mbak
low.
Yan ya.
It means that the risk of QT prolongation is not more than placebo itself when we don't combine it with the chloroquine, but it's become dangerous when we combine it with chloroquine. So you see here that we careful when we use chloroquine or other antiviral, we have the impression that other antiviral potentiation for arrhythmia, even that's fine. For antivirals is very big question.
Okay. Thank you, Dr. Nafriati, but I'm sorry that your voice is not clearly. Maybe I hope the other participants or attendee can hear your voice clearly, but I'm sorry, as a moderator, I can hear your voice clearly. But I think maybe Dr. Khairul or Dr. Khairul first, please comment the opinion of Dr. Nafriati.
Yeah, thank you very much, Dr. Nafialdi. Sorry, there was a technically issue that I couldn't hear it clearly. Okay, for the first, it's about secondary bacterial infections that COVID-19 patients. There is no sub-analysis in that study with asymptomatic or mild or moderate or severe patients, because I think that is very important. That's true. we have to know uh, what the cluster of the patients that have this atypical pathogen infections. And then for the second one, yeah, this is very interesting that um, it's about New York study, I think. Um, Azithromycins, when we compare with placebo or control, it in terms of neither drugs, nor hydrochloroquine, nor azithromycin. Um, yeah, azithromycin is very good result when we compare to hydroxychloroquine. Azithromycin alone can prevent cardiac arrest and mortality 21. To me, it's very significant in clinical uh, impact, but in statistical there is no significant difference. But here we need to again we need to investigate further about the impact of azithromycin alone with robust methodology, and I think that is from azithromycin. Dr. Arifa.
Okay, thank you, Dr. Khairul. Maybe the second opinion from Dr. Deliana. What's your comment about the opinion of Dr. Nafrialdi?
I agree with Dr. Nafrialdi that the anticoagulant heparin can be given for the therapy, but can also give as a prophylaxis. I want to share my screen. Um, Actually, I have mentioned this before as the strategy of administration of anticoagulant. Here we can see that when to start the anticoagulant. We can give the anticoagulant as a prophylaxis if the D-dimer is increasing, but the fibrinogen is very, and the PTA, PTT, and thrombocyte still normal. And we can give the heparin as the therapeutic drug if the D-dimer is increasing, the fibrinogen increase or decrease, and the PTA-PTT is prolonged, and the thrombocyte is normal. And we can still give the heparin when the thrombocyte is decreasing, but the cutoff point is 25,000 of platelet from the laboratory finding. Like my previous strategy. Is it clear? Is it clearly seen here that I'm sorry, is it, it should be a slideshow, sorry. Here is.
Yes, we can see your PPT.
Yes, we can still give the heparin as a therapy for the thrombocyte, for the increase of thrombocyte, but the cutoff point is 25,000. In other cases, like thrombocyte in normal range, we can give the heparin freely.
Maybe Dr. Nefrialdi would like to share another opinion or another question.
Yes, I agree. Even when the thrombocyte count is good, it's time to start the heparin. But providing that dimer is increased already, without waiting for a more severe condition. Yeah, yeah, I agree.
Okay. Thank you for Dr. Nafriadi from our panelists, Dr. Nafriadi and Dr. Maftuha. So I would like to invite Dr. Nurina. Maybe you can give a question to Dr. Diliana.
Okay, thank you, Dr. Diana, for your nice presentation. I would like to ask you whether do you have any experience or knowledge of the using of NOAC for COVID patients? Is there any benefits or it is probably unuseful? Thank you.
Okay, Dr. Deliana, you can answer the question directly.
Well, actually, for the NOAC, I have limited experience about this, but um, what I have seen about the NOAC, usually the bleeding risk um, is vary in individuals. It can um, some individuals bleeds early after administration, but some not suffering bleeding after the administration of NOAC and OAC. That's my answer. Is that quite clear?
May I add something, Dr. Arifa?
Yeah, oh, it's okay, Dr. Nalpriyanti.
Yeah, the second problem, I think that NOAC works not very fast. The onset is too late, I think. Because, yeah, that's the consideration why not using the NOAC. Why we prefer to give heparin because it works more directly than NOAC. But NOAC maybe we should wait until 2 or 3 days before it works.
Okay, Dr. Nurina, are you
Thank you.
satisfied?
Thank you.
Are you satisfied, or you want
Thank you,
to ask
Dr.
again
Dili and Dr. Nafriadi.
about when we use the NOAC or when we use the heparin in the late stage to the prophylaxis or the treatment? No, it's enough.
Yeah.
Yes, thank you. Yes, thank you.
Thank you for Dr. Nurana. There is some question from the participants, or both in Bahasa and English. For Dr. Khairul Purba, the first question is, berapa lama pemberian azithromycin dan bagaimanakah kemungkinan dengan resistensi antimikrobal? Please,
Yeah.
Dr. Khairul.
Switch to bahasa. Oke,
Yes.
Oke, thank you. Terima kasih atas pertanyaannya. Azithromycin itu secara pemberiannya kita berikan sehari sekali, biasanya 500 mg cukup, karena dia termasuk yang concentration dependent atau time dependent juga. Kalau dinaikkan menjadi 3 hari, maka konsentrasi dalam sel darah putih atau makrofagnya itu meningkat, atau di jaringan juga meningkat. Jadi semakin lama diberikan azithromycin, semakin tinggi kadarnya dalam tubuh kita. Nah, berapa lama idealnya? Ya, studi mengatakan 5-7 hari. Itu idealnya pemberian azithromycin. Sebelum kita memberikan antibiotik secara rutin ya, kita harus melakukan pengambilan darah, sampel darah atau sputum untuk mengetahui penyebab apakah memang ada bakteri pada tubuh pasien. Nah, itu sekaligus saya menjawab tentang resistensi antimikroba. Ya, penggunaan antibiotik yang tinggi itu sebanding dengan resistensi antimikroba. Jadi harus hati-hati juga, tidak bisa lama kita memberikan antibiotik ya. Meskipun kita mengharapkan efek imunomodulasinya, namun kita harus sadar bahwa azithromycin bukanlah imunomodulator saja, tapi dia awalnya dan memang antibakterinya cukup besar. Jadi harus hati-hati penggunaan azithromycin ini. Dan apakah ada data untuk ini? Untuk resistensi antimikroba terhadap azithromycin pada pasien COVID belum ada. Mungkin kita bisa nanti ya meneliti hal ini. Cukup bagus. Itu mungkin, Dr. Arifah.
Terima kasih Dr. Khairil. Kebetulan ada juga pertanyaan dari Dr. Suharjono berkaitan dengan azithromycin. Apakah mungkin ya diganti dengan clarithromycin dan doxycycline atau minoxidil pada pasien dengan gangguan QC? Dan doxycycline, minoxidil bisa untuk malaria juga seperti hidrohcq.
Terima kasih Prof. Suharyono atas pertanyaannya dari Farmasi Universitas Erlangga. Cukup bagus sekali. Ya, makrolet begitu banyak pilihannya. Yang kita kenal ada erythromycin, azithromycin, sama clarithromycin. Ya, pertanyaannya apakah kita bisa ganti dengan clarithromycin? Bisa ya, clarithromycin sama azithromycin itu efeknya sama, sama-sama makrolet juga. Namun yang kita harus ketahui di sini adalah drug-drug interaction-nya, bahwa azithromycin itu sangat minimal untuk pharmacokinetic, meskipun kita dapat data untuk pharmacodynamic interaction, seperti azithromycin dikombinasi dengan hydrochloroquine yang meningkatkan outcomes dari cardiac arrest atau aritmianya. Pharmacokinetic tidak ada interaksi antara azithromycin dengan beberapa obat yang lainnya. Tapi kalau clarithromycin harus berhati-hati karena dia berkaitan dengan metabolisme, ya. Jadi inhibitor dari CYP3A4, sehingga harus hati-hati jika kita mengkombinasi dengan obat-obat lainnya. Itu catatannya untuk clarithromycin. Untuk doxycycline sama minoxidil jarang kita gunakan untuk pasien yang severe atau moderate infection. Ya, secara teori ya, mungkin secara data saya belum menemukan secara evidence yang kuat. Doxycycline sama minoxidil harus hati-hati dengan adanya diare, pseudomonal diare. Itu yang biasanya kita temui di klinis jika penggunaan doxycycline atau minoxidil dalam jangka waktu lebih dari 3 hari. Itu mungkin, Dr. Arifah.
Oke, terima kasih Dr. Khairul. Sehubungan lagi masih berkelanjutan, sekalian saya lanjutkan pertanyaan dari Edi Z. Purnama tentang data penelitian tentang recovery dan mortality pemakaian dari HQ plus azithromycin, mungkin maksudnya kloroquine dengan azithromycin dibandingkan dengan hidroksikloroquine atau azithromycin saja di Indonesia. Karena data yang ditampilkan adalah Amerika ya, yang kebanyakan rasnya memang berbeda ya. Apakah ras mempengaruhi ya masalah efek samping obat rasnya di sini. Mungkin Thailand menghindari azithromycin karena dianggap meninggikan risiko kematian pada COVID-19, pada pasien COVID-19. Silakan Dr.
Ya. Ini ya terkait dengan genetik ya, memang datanya dari New York study, sangat saya tidak mendapatkan dari Indonesia. Cukup bagus kalau Indonesia membuat data hanya memberikan pada pasiennya azithromycin saja. Saya kira ada ya penelitian di Indonesia yang tidak menggunakan hidroksikloroquine atau chloroquine, karena hidroksikloroquine itu sudah tidak mudah untuk mendapatkan hidroksikloroquine, kebanyakan menggunakan chloroquine plus azithromycin. Dan ada juga yang penelitian terkait dengan azithromycin saja, karena efek samping dari hidroksikloroquine. Nah, mungkin kita wait and see ya berikutnya apakah data itu dipublish. Kita tunggu, kita berharap saja ada perbedaan antara Indonesia dengan luar negeri. Tapi secara konsep farmakologi untuk azithromycin dia tidak ada tidak ada perbedaan di dalam, dia tidak berhubungan dengan metabolisme, dia hanya berhubungan dengan ekspresi hepar. Mungkin enzim metabolisme tidak involved pada azithromycin ini. Jadi seharusnya sama, tidak tergantung dengan genetik. Ya, tidak tergantung dengan genetik. Jadi harusnya sama outcomes-nya di antara pasien di New York atau di Thailand atau di Indonesia, harusnya sama. Dan mungkin kematian yang tinggi pada azithromycin butuh foto analisis multivariat. Mungkin banyak faktor yang terlibat dalam outcome klinisnya. Mungkin itu, Dr. Arifah.
Terima kasih Dr. Carol. Jadi secara literatur review memang belum ada bukti yang kuat atau cukup bahwa faktor genetik akan mempengaruhi baik khasiat maupun efek samping dari azitromisin ya. Begitu ya Dr. Carol.
Ya, benar.
Oke, ada pertanyaan dari hasil Chandra. Dr. Purba, I wanna ask a question. As Faviravia can effectively use in COVID-19 medication, and as the combination of Faviravia, azithromycin, and remdesivir can be used in COVID-19 medication.
Okay, thank you for the questions. Fondaparinux maybe can be answered by Dr. Dili. Yeah, and to me, the combination between fondaparinux, azithromycin, and remdesivir, three drugs, I think it's very nice combination for life-threatening patients. Azithromycin has immunomodulating properties, and the remdesivir has good results when we have a look the result from the European countries or American publications. And then fondaparinux maybe help in the coagulopathy in the patients. So to the questions, the combination is very good to me, and yeah, maybe it will be nice combination. And about the effectivity of fondaparinux, maybe Dr. Gilly can be describe more.
Okay. Terima kasih. Thank you, Dr. Khairul Purba.
Yeah,
there are some questions from Dr. Juliana. In bahasa, Dr. Juliana, apakah boleh mengkombinasikan dua macam obat antikoagulan pada pasien COVID-19 dengan kadar D-dimer yang sangat tinggi? Dan berapa lama penggunaan antikoagulan pada pasien COVID? Silakan Dr. Juliana.
Jelaskan dalam bahasa atau bahasa Inggris?
Dalam bahasa tidak masalah, karena pertanyaannya dalam bahasa.
Ini kalau yang untuk pertanyaan dari Hazel Chandra tadi, saya ingin menambahkan saja bahwa sebenarnya untuk pengobatan kombinasi ini pada COVID-19 bukan sebagai kombinasi, tapi adalah karena adanya peningkatan D-dimer. Nah, kalau pasien ini confirm COVID-19, tapi D-dimer tidak meningkat, saya rasa tidak perlu direkomendasikan untuk pemberian fondaparinux maupun obat-obatan antikoagulan lainnya. Jadi, tapi karena banyak pasien-pasien yang confirm COVID-19 itu D-dimernya meningkat, maka diberikan obat-obatan antikoagulan, contohnya fondaparinux. Tapi tentunya biasanya yang tinggi D-dimernya itu adalah yang pasien-pasien yang hospitalized, yang dirawat. Pasien-pasien yang outpatient, pasien rawat jalan, umumnya D-dimernya tidak meningkat, sehingga tidak perlu pemberian fondaparinux ataupun antikoagulan lainnya. Kemudian untuk pemberiannya berapa lama? Untuk pasien rawat inap, tentunya kita bisa memantau faktor-faktor pendarahan, resiko pendarahannya. Kalau misalkan misalkan contoh ya, 1 minggu dia tidak ada pendarahan, ya obatnya bisa diteruskan. Yang penting kita ingin mencapai target D-dimernya di angka normal, range-nya. Gitu. Tapi kalau misalnya ternyata kita belum mencapai target untuk angka D-dimer, ternyata pasien sudah pendarahan. Saya rasa sih kita harus wise untuk menghentikan sementara obat ini, sehingga biarkan si pasien itu pendarahannya berhenti dahulu. Gitu. Kira-kira begitu apa?
Oke, satu lagi Dokter Diliana, kalau kombinasi Dokter Diliana, bagaimana menggunakan kombinasi lebih dari satu macam antikoagulan?
Kombinasi untuk lebih dari satu macam antikoagulan sebenarnya sih meningkatkan risiko
maaf koneksinya agak kurang bagus ya. Mohon maaf saya sebagai moderator tidak bisa mendengar dengan jelas jawaban dari Dokter Diliana. Halo, Dokter Diliana. Halo. Terputus ya Dokter Diliana. Mungkin
gambarnya freeze.
Barangkali Dokter Nafrialdi bisa memberikan mungkin semacam suggestion atau pendapat tentang penggunaan lebih dari 2 macam antikoagulan.
Biasanya antikoagulan itu kita nggak kombinasi ya, bahkan kondisi berat pun, contohlah yang orang bertarung dengan nyawa pada infark miokard, antikoagulannya heparin atau sejenisnya, heparin low molecular weight atau fondaparin salah satu. Saya nggak tahu nih pertanyaannya apakah yang dimaksud itu yang antiplatelet disebut sebagai antikoagulan, karena istilah farmakologi kan antiplatelet beda, antikoagulan beda gitu ya. Nah, pada kasus di IC ini yang logisnya itu adalah karena koagulasi kasketnya itu yang lebih logik itu adalah kita sudah mulai di dalam fase pembentukan trombus itu di heparin yang lebih logis, karena kayak itu misalnya apakah antiplatelet masih berguna, ini saya kira perlu penelitian juga, karena begini, kalau kita ambil contoh pada orang infark itu terapi awalnya kita berikan antiplatelet cukup tinggi. Nah, kemudian kita baru tambahkan antikoagulan. Nah, untuk COVID ini yang selama ini masih kita sampai sekarang ya masih dihipotesiskan oleh para klinisi pakai antikoagulan, heparin dan sejenisnya. Nah, tapi apakah antiplatelet kayak clopidogrel atau aspirin bermanfaat atau tidak? Nah, ada penelitian kecil dari Spanyol kalau nggak salah mengatakan mereka memberikan dari awal aspirin atau clopidogrel dan itu hasilnya bagus ya. Tapi itu juga kembali lagi bahwa banyak penelitian yang begini dengan sampel kecil tidak randomized gitu, sehingga kesimpulannya juga agak sulit. Tapi ya nice to think about that, whether we should combine antiplatelet or base anticoagulant ya. But anticoagulant we only use one, heparin or low molecular weight heparin or fondaparin, you choose kan. Tapi bisa tambahkan antiplatelet, bisa atau tidak. Nah, satu lagi yang jadi jajaran itu tentunya adalah trombolitik. Nah, ini yang tidak lazim. Kalau dia trombosis di pembuluh darah kecil, kita tidak memberikan lagi trombolitik. Itu hanya berlaku untuk pembuluh darahnya agak besar. Jadi saya kira begitu. Kita belum bisa jawab, tapi perlu dipertimbangkan ini ya, harus ada penelitian lagi yang membuka ide nih. Mungkin jangan-jangan bisa bermanfaat gitu ya.
Ya, mungkin perlu ada suatu penelitian ya, kalau antikoagulan apa mungkin kan kita kombinasi dengan trombolitik atau antiplatelet. Sama satu lagi Dokter Nafrialdi, apakah ada perbedaan di pemilihan dari obat-obat baik antikoagulan atau antiplatelet atau trombolitik pada pasien-pasien COVID-19 antara yang rawat inap, kemudian dinyatakan sembuh, dan kemudian pasiennya dilanjutkan dengan rawat jalan, itu apakah ada perlu tetap diberikan antikoagulan atau di-switch dengan antiplatelet atau kemudian trombolitik, atau apakah ada protap seperti itu?
Saya sendiri berpendapat nggak perlu ya. Bahkan yang rawat inap, begitu kondisinya membaik, sudah. Itu heparin kita stop. Karena setelah itu tidak ada lagi fenomena yang prone untuk DIC itu. Jadi tidak logis juga kita perpanjang, karena beda dengan hiperkoagulasi yang misalnya kayak genetik, orangnya seumur hidup dikasih warfarin. Ini enggak, ini kan kondisi yang sangat transien. Itu selesai, orang survive, sembuh, ya sudah selesai. Itu pendapat saya.
Kemudian penggunaan NOAC tadi, bagaimana?
Kalau NOAC, saya nggak melihat itu cukup tepat ya, karena dia kerjanya itu butuh waktu yang agak lama. Diminum sekarang, efeknya baru 3 hari kemudian, gitu ya. Yang kayak warfarin misalnya. Tapi kalau DOAC, direct action gitu ya, kayak dabigatran, nah itu ada literaturnya, ada penelitian kecil yang mengatakan mereka memakai itu. Ya, itu tentunya untuk kondisi yang ringan, yang berobat. Cuman berobat ringan, berobat jalan itu agak anehnya begini. Kalau ringan rasanya tidak perlu kita kasih itu karena daya imunnya tidak meningkat, di ICU juga belum berproses ke sana. Namun walaupun demikian memang ada yang katanya begitu dia masuk gejala ringan dimasukkanlah drug tadi, direct acting antikoagulan, atau bahkan yang tadi saya sebutkan antiplatelet, ya, aspirin dosis kecil, ataupun juga misalnya clopidogrel. Ya. Itu yang kita belum tahu jawabnya. Yang gitu itu kita nunggu dulu berapa data yang ada, ya sebenarnya ini efektif apa tidak. Jadi tidak bisa dijawab.
Terima kasih Dokter Nafri. Dokter Juliana sudah kembali, Nje. Monggo dilanjutkan tadi. Mohon maaf Dokter Juliana tadi sempat terputus.
Mohon maaf tadi keputus. Ya, tadi bicarakan mengenai kombinasi ya?
Ya, kombinasi dari dua macam antikoagulan.
Iya, kombinasi dari dua macam antikoagulan. Ya, tidak jauh berbeda dari penjelasannya Dokter Naf. Jadi memang itu boleh saja diberikan kombinasi, tetapi kita harus waspada akan resiko pendarahannya, karena kan pasti lebih tinggi nanti resiko pendarahannya. Gitu.
Terima kasih Dr. Dilana. There is another question from Ahmad Jayadi. Can cycle threshold CT value been used to assess when a person is no longer infectious?
Ini aku jelaskan dalam bahasa atau in English ya?
Terserah Dr. Juliana. Monggo. Bahasa juga.
Oke, dia bertanya dalam bahasa Inggris ya. Oke, I will try to answer in English. The CT or cycle threshold values is the result of the CT is we can have it from the PCR of swab nasopharyngeal. What I want to say is the result is giving information that the more the machine rotate, the smaller the virus can be found. So when the CT value is more than 30, I give the cutoff point is the CT value is more than 30, we can say that this patient is not infectious for the COVID-19. But the smaller the value, the more infectious patient is. Jadi dalam bahasa maksudnya adalah PCR ini kan mesinnya berputar. Jadi semakin banyak putarannya, artinya semakin sedikit virus yang ditemukan. Semakin sedikit virus yang ditemukan, berarti kita bisa berpikir pasien ini mungkin semakin tidak infeksius. But the problem is this laboratory microbiological findings is not approved by FDA as the findings that we can use to check whether the patient is infectious or not infectious. Jadi FDA belum menyetujui ini sebagai pemeriksaan penunjang yang bisa kita pakai. Gitu kira-kira. Sebenarnya ini di luar konteks farmakologi ya, tapi ya ini penting juga sih untuk kita ketahui.
Ya, terima kasih ya Dr. Juliana atas penjelasannya. Ini ada satu pernyataan dari peserta ya Muhammad Arkaf, bahwa mungkin Dr. Juliana bisa menanggapinya, bahwa menurut AWCS Antiplatelet itu tidak ada perannya kecuali kebetulan ada risiko arterial trombosis, serangan stroke akut, serangan jantung akut ACS. Monggo, mungkin tanggapan dari Dr. Diliana.
Aduh, internet connection unstable. Ini jadi pertanyaan
Tidak
gimana
pertanyaan
ya?
ini, Dr. Diliana, satu pernyataan mungkin bisa menanggapi bahwa menurut
Pernyataan.
pernyataan bahwa antiplatelet tidak ada perannya kecuali kalau kebetulan ada faktor risiko seperti arterial trombosis gitu. Monggo, silahkan Dr. Diliana.
Memang sih kalau yang kita tuju ini kan faktor koagulasinya yang di faktor 10 ya. Sementara antiplatelet adanya di perifer. Saya sih setuju ya dengan pernyataan ini. Karena memang terutama untuk COVID-19 ya, karena kita mau kasih pemberian itu agak lebih dini, yaitu di faktor 10-nya, bukan di blood vessels-nya gitu. Kira-kira gimana jawaban saya, apakah cukup jelas atau?
Saya kira cukup jelas, atau mungkin Dr. Nafiati bisa memberikan tanggapan yang lain. Oke, terima kasih Dr. Diliana. Mungkin masih ada pertanyaan lagi ya untuk Dr. Khairul. Silakan Dr. Nurina untuk memberikan pertanyaan.
Kepada Dr. Khairul, yang saya tahu bahwa beliau cukup banyak meneliti masalah sepsis di Indonesia. Kita melihat tadi juga sudah dipaparkan datanya oleh Dr. Diliana di Rumah Sakit Persahabatan, cukup tinggi angka pasien COVID dengan penyulit sepsis di Indonesia yang berujung pada kematian begitu. Barangkali Dr. Khairul bisa memberikan komen kira-kira faktor prediktor apa yang menyebabkan seseorang, dalam hal ini khususnya pada pasien COVID itu bisa jatuh pada kondisi sepsis ya, yang seringkali kita kaitkan dengan cytokine storm. Mungkin juga komen dari Dr. Diliana, kira-kira mungkin faktor apa saja yang menyebabkan angka kejadian sepsis ini cukup tinggi di Indonesia. Kalau mungkin kesannya dibandingkan Thailand tadi sepertinya mereka tidak cukup banyak. Terima kasih.
Iya. Siapa dulu ya? Saya atau Dr. Dili?
Silakan Dr. Khairul dulu.
Dr. Nurina, matur nuwun atas terima kasih atas pertanyaannya. Ya, sepsis itu sangat tinggi sekali ya insidensnya, terutama untuk pasien COVID ini juga. Mungkin pasien COVID ini juga meninggalnya karena sepsis ya kebanyakan. Ya, secara patofisiologis sepsis ini juga terkait dengan cytokine storm ya. Kemudian kita tidak mudah untuk menangani sepsis jika terjadi antimicrobial resistance. Tidak pada pasien dengan sepsis itu imunomodulasinya sangat ada terjadi disregulasi dari imunologi di dalam tubuhnya, sehingga kita juga harus mempertimbangkan pengobatan-pengobatan lainnya ya untuk life threatening. Mungkin karena sudah severe ya sepsisnya, maka kita melihat penelitian-penelitian seperti di UK itu ya, kita melihat adanya kombinasi dengan dexamethasone karena ya tadi cytokine stormnya sangat tinggi sekali. Terkait dengan antimicrobial resistance, maka kita harus bijak dalam menggunakan antibiotik ya, karena kalau sudah sepsis dengan antimicrobial resistance atau multiple drug resistance organisms, maka tidak mudah kita mengobati pasien dengan antibiotik. Maka yang kita berikan hanyalah supportive treatment ya. Tapi ya itu tadi tidak menjanjikan juga ya. Kita hanya memberikan supportive treatment, bukan etiology treatment. Ya, untuk terapinya mungkin antibiotik itu harus diberikan secara benar dengan bijak ya sebelum terjadi AMR atau antimicrobial resistance. Kemudian imunitas pasien juga jangan sampai kita membantu dengan kita berikan dexamethasone atau ya steroid. Ini mungkin out of the context, tapi ya kondisi sitokom badai sitokom ini cukup jelas pada pasien sepsis maupun pada pasien COVID. Ya, tapi harus hati-hati penggunaan steroid itu hanya pada pasien yang severe, tidak moderate, tidak mild. Itu mungkin dari saya, Dr. Nurina.
Terima kasih Dr. Purba. Dr. Nurina mungkin masih ada pertanyaan lagi atau sudah cukup?
Mungkin message yang saya tangkap dari Dr. Hairul tadi, mungkin kita perlu menelaah kembali ya problem antimicrobial resistance di Indonesia yang perlu untuk di manage dengan serius.
Yep.
Terima kasih Dr. Hairul.
Sami-sami.
Terima kasih. Finally, allow me to emphasize the important thing of this discussion. The management treatment of COVID-19 need multiple approaches according to the clinical symptom and sign and the examination supporting. And also we need a wide collaboration to do research or about the prevention, treatment, and rehabilitation. Before I return to the house, as an appreciation, the committee gave the certificate to Dr. Diliana SPFK. Thank you, Dr. Diliana, for your participation, and we will hope we can develop a nice collaboration about the research, especially into anticoagulant and antiviral or antibiotic treatment. And the next certificate, okay, thank you, Dr. Juliana. The next certificate for Dr. AKR Purba, SPFK, MSc, and PhD. And
yeah, thank you very much.
Thank you very much, Dr. Khairul, for your nice presentation, and I'm glad that you gave an excellent lecture for us. The next certificate for our beloved panelists, Dr. Nafrialdi SPFK, SPPD, and PhD.
Thank you very much.
Thank you very much, Dr. Nafrialdi. I hope we can develop the future in the research collaboration. And thanks to Dr. Maftuha, Romanti, Dr. MKS as yours supporting in this conference. Lastly, Dr.
Thank you.
Time it's yours.
Okay, thank you very much, Dr. Arifah, distinguished speaker, panelists, and participants. We reach the end of our event today. We hope our discussion today can broaden our knowledge and also trigger our curiosity. We hope the new research idea and collaboration can be born from this event. Thank you very much for the committee, and for participants, please do not forget to fill the post-webinar survey that the link already shared in the chat box. Thank you very much for all. We seek to meet you again in the future. Terima kasih semuanya.
Oke, terima kasih ya. Terima kasih Dr. Nana.
Untuk tim nggak foto dulu, nggak ada foto session.
Mungkin bisa ya di screenshot
foto session. Foto session. Ayo, foto session ya.
Ini sebenarnya panitia ini fresh graduate semua ya. Saya masih ingat kok.
Ada yang mahasiswa kok, ada yang mahasiswa.
Oh ya, Wina, ini saya masih ingat semua ini.
Rahul belum lulus, Rahul.
Oh, Rahul kan ini masih mau DM ya kayaknya ya Rahul, atau masih klerek ya?
Ya dokter, ada beberapa kamar yang flashback.
Makasih ya, bantuannya sangat berharga loh.
Ayo foto dulu, buka
Ya, dokter.
videonya dong.
Semuanya boleh di start
Iya,
video.
buka
Dokter.
video.
Iya.
Ada yang belum pernah ketemu ini. Mungkin kita sudah pernah ketemu ya, tapi ya lupa-lupa ingat ya.
Iya, iya. Oke, siap ya. Mungkin dokter Khairul sudah start video, dokter?
Bentar, sudah. Dokter Sri, Dokter Danti, Dokter Nurma, Dokter Bambang, monggo.
Maaf ya, partisipan tidak bisa ikut.
Partisipan udah live duluan.
Masih banyak.
Masih banyak.
Tadi total berapa ya yang join ya?
Ini maksimal
Akhirnya
400-an dokter, 420.
450-an ya nyampe ya.
Yang register
Lebih,
400, yang akhir
480-an lah.
join.
Dokter
Kadang
Khairul
lupa kok, kadang lupa. Dokter Khairul sudah itu?
belum tampil di sini.
Tampak.
Dari sini.
Ya sudah. Nah itu Dokter Khairul.
Oke, saya mulai ya.
Ya.
Siap. Foto dalam 3, 2, 1. Oke. Sekali lagi ya, dokter ya. Biar lebih mantap, dok.
Ya.
3, 2, 1. Ya.
Ada suaranya ya?
Biar kerasa.
Ya itu mantap, itu namanya mantap, itu cekliknya harus ada.
iya.
Kalau enggak terasa di foto. Terima kasih adik-adik, excellent sekali adik-adik.
Iya.
Ya,
Ketemu lagi insya Allah
Terima
DM
kasih ya,
nanti ya.
Terapi.
Ya, sama-sama. Ya.
Warna
ini saya jadi
rambutnya berubah
kepingin
ini.
melaksanakan webinar lagi nih, gimana ini ya?
Iya, Terapi.